How's that? Okay. So we would do the draping. He would already be draped the way that we were doing it before. So I'm not going to demo that because we're just doing lower leg right now. Obviously, you would integrate this with the entire leg. So once you get the thigh, once you run the knee maybe a little bit, then you work your way down to the lower leg. However, we're going to do a little bit warm up just above that. And you notice one of the things that we talk about on occasion is the leg position. So if you see someone whose knee and foot is outturned, is in lateral rotation, what do you think that indicates? Yeah, maybe tight glutes. So ultimately, I would see this and think, okay, so maybe I'm going to spend some time on the glutes, or I would ask, work on your glutes today, or would you like your glutes addressed today? Because even if I reset, yeah, it's like I can hold it there, but yeah, it's going to relocate itself. So, and if this was something that I saw on a visual assessment, you know, I would plan it in ahead of time. But if it's something that I didn't see or I didn't get a chance to see and then was just noticing now, I might reconfigure my plan in my head to include some. Okay, so mostly what we're going to be focusing on in the lower leg are the muscles on the lateral side. What do we have right here? Yeah, tibialis anterior, and that comes all the way down the leg here and then goes where? Underneath medially, underneath laterally. Yeah, goes down and attaches to the bottom of the foot right there. Yeah, medial cuneiform. Yep. And then on this lateral side, we also have these. What are these? Right, fibularis longus and brevis or peroneus longus and brevis. I still refer to them as the peroneals. That's stuck in my head, although I know your book calls them the fibularis or fibulares, and yeah, that's fine. So these muscles tend to get pretty tight. Mostly tibialis anterior hypertonicity is going to present with an inversion of the foot, whereas peroneal hypertonicity would be an eversion of the foot. We can also use the lower leg here as a vehicle to what muscles right here? Soleus. Yeah, soleus. So if we really need to get to soleus, this is actually a great position to do that. Now, I will show you how to do it when your client is prone, but right here, you have perfect access to it. All you need to do is slide off the tibia here and you're on soleus. And it's pretty bulky. And this is also a nice position because it gets gastroc out of the way. You know, normally you're kind of working through gastroc to soleus, but in here, you're right on soleus. All right, so we'll start with a bit of a warm up. I'm just doing a spreading. And of course, the other muscles in here, the deeper flexors and extensors of the toes, we can't directly palpate. So you can do some of the same things you were doing on the forearm. You can do petrissage. Anybody petrissage down here? Obviously, you don't want to be petrissaging the bones, so the force is in your fingertips and you're not pushing down into that. I like petrissage. I think it feels nice, especially if you start at the top and just kind of work your way down. Or you get a little bit of that knee petrissage in there and then move down to the lower leg or something like that. It feels a little more connected. Okay. So if we're working on tibialis anterior, I need to see what I'm doing. So remember, you control the body. So you can hold at the knee or you can hold at the ankle, whatever your dominant hand is that you like to work with. Okay. Doesn't really matter, or you could switch, whatever. But since we're going to be on this side, I don't want to be bending over for my body mechanics. So I'm going to start with an inversion of the foot and ankle so that these come up to meet me. And I have put them in a lengthened position, and then start with the soft fist. Now remember, the head of the fibula is up here, so you don't want to go bone on bone. So you don't want your knuckles to come over the bone, just like anywhere else. And you notice my body's not moving a whole lot because I'm not really going that far. And when you come back down, you can let the body relax a little bit, but ultimately you want to put it back. This is not technically a pin and stretch, but if I wanted to add a little bit more flexion and inversion, I could turn it into a pin and stretch. So this is softening up a little bit, but I want to do a little bit more in here. You can work knuckles. You don't really want to, like the forearm, you don't necessarily want to work down here. It's too tendinous, too bony. It's not going to feel good for your client. You want to stay where the muscle bellies are. Is that okay, Nate? And then, of course, you can do a little bit of cross fiber on the tendinous attachments. So right up near the head of the fibula. Is that pretty tight? Yeah, I mean, I can right in here. There's twangy. You can, if you feel so inclined, do some forearm. Elbow, not so much. You're not really going to get in there with that. But this is also an area where we can do a little bit of decompression on the muscle tissue. Remember when we were up in supraspinatus and we were pulling the tissue away from the bones? We were creating space in the tissue instead of pushing into it like we normally do with massage. This is another area that we can do that. So tibialis anterior attaches right to the tibia here. So we're going to take our thumbs next to each other like this, right on the lateral side of the tibia, and we're just going to push the tissue down towards the table. So we're pushing it away from the bone. We're pushing it down towards the table. And I have to really watch my thumbs because they want to do this. And we're just working our way down the tibia. And you'll know when you get on a spot because your client will say, ooh, that's tender there. And you might feel the adhesion. You might feel where it is stuck to the bone a bit. This is really great for shin splints. So if you have any runners or athletes, like right in there. Yeah, right in there. I'm feeling it's not separating a whole lot. So here would be an area that I might focus on. And if I'm going to, I can come in and do a little friction in that area because it's pretty tendinous down here. or I can hold and wait for softening. Now I'm using a thumb, but I can use any smaller tool. So I can use knuckles, reinforced knuckle. Okay. Or I can just do some circular friction. You know, whatever your client can tolerate. Circular friction.
You're doing circular friction with the thumbs. Are you going opposite each
I
other?
was going in opposite directions. But that's personal preference. It doesn't matter. You can do like a window wiper thing where you're or opposite directions or the same direction. Yeah, it doesn't. Circular friction, it doesn't matter. It's whatever you choose. Okay. You can do that up in at the top of the peroneals as well, near the head of the fibula. A little bit of circular friction. He was also indicating that that is an area that's pretty tight and tender. Okay. Feel good? Or you can do the hold and wait for softening. Remember, trigger points tend to be in the belly of the muscle and at the myotendinous junction. So you're likely to find them up near the head of the fibula, maybe a little bit lower, closer to the ankle, or again, you can right in the belly of the muscle. Tibialis anterior does tend to be in the belly, about halfway, 2/3 of the way down. Okay, so if you do find trigger points in here, they will refer. They will refer mostly distally, and then you do your trigger point technique. Breathe in, breathe out, sink it. Okay. All right. So if you have runners or athletes or even just moms who are on their feet all day, this is a really nice stretch, and you can continue this up onto vastus lateralis, and you can actually go all the way up to the hip when you have your draping, the way that I showed you yesterday. And then you can connect the lower leg to the thigh and to the hip. You can also work around the ankle and foot in this position. You know all of the things that you were shown in Swedish, but you can also get in a slightly different position. So you're used to working the foot facing it, but if you don't, that's okay. Right? You have a little more pull this way. Right? You can use your body weight to pull through the arch, the medial longitudinal arch here, and to get some range of motion in the ankle. Like, it's not petrissage, but it's petrissage-ish in here. You can do some actual petrissage or circular friction. So knock somebody up. Especially if they've been on their feet a lot, like fellow massage therapists. It's good stuff. The only thing you really need to be aware of is if, pardon me, somebody says on their health form that they have plantar fasciitis, you don't want to pull towards the toes because you're actually pulling the plantar fascia away from the calcaneus. You just need to be mindful of the direction that you're going. So you do want to move everything towards the calcaneus if they have plantar fasciitis, not away. And they may have trigger points. You know, some of those toe flexors. And through here, you might find something just like in the palm and on the thenar eminence. You can have trigger points in here. Sometimes you can have them in the feet too. So this is just a different position. Maybe try it out, see if you like it, see what you can do with it. Okay. I mean, you can get in this position too, but I always find this one to be a little more awkward because I feel like I have to get way down in order to do this, or I end up bending at the waist. Okay. So you finish with the foot, holding on to the foot. You pull your drape. Remember, you just pull straight down. Cover the foot. Replace. I never take my hands off. Go to the other side and stage it. So I'm here now. This is where I am. My client's got a sensory cue that I'm on this leg just for a second or two, 1, 2, and then undrape the leg. That helps to connect them through the entire massage and to keep them in that parasympathetic. All right, let's go try that. Thank you.